Oh, there we go. Good afternoon, everyone. Thanks so much for joining us for this last breakout session. My name is Akin Demehin. I'm Senior Director for Public Policy at the American Hospital Association. I am a Black male, and I am really delighted to have the honor of moderating this final session. And the title of this session is Improving Health Equity for People with Disparities Through Inclusive and Accessible Health Care. And we have a large panel of experts to join us to provide their perspectives. So we're going to have a total of 3 presentations offered by the panelists here. I'm not going to get into each of their individual bios. Needless to say, however, they bring an incredibly rich background and perspective to this particular conversation. Their specific bios are listed on the conference website. So first, we are going to hear from Amber Christ and Teresa Nguyen, who will present on an equity framework for evaluating and improving Medicaid home and community-based services. We'll then hear from Andy Burstein, who will talk about medication management for people with disabilities and refugees. And then finally, we'll hear from Dr. Madeleine Shea and Dr. Erica Reaves about priorities for housing services and supports identified by Georgians with intellectual and developmental disabilities by their caregivers. And what I'll ask each of these folks to do when they present is to say just a little bit more about themselves and about their organizations. So without further ado, let's hear from our first presenters.
Thank you so much. I was told this was on.
It should be done.
Can everyone hear me? Okay, awesome. Good afternoon, everybody. My name is Teresa Nguyen, and I'm here with Amber Christ to talk a little bit about equity in home and community-based services and a framework that was developed to guide our research. Next slide, please. Thank you. So I'm going to be talking a little bit about the Community Living Equity Center, which is housed at Brandeis University. The center was developed under a grant from the National Institute on Disability, Independent Living, and Rehabilitation Research, also known as NIDLR. And the contents of this presentation do not necessarily represent the policies and views of NIDLR. So just an overview of the center. Research has been conducted on how disabled people of color access, use, and experience and are affected by education, healthcare, and employment systems, but little has been done to understand racial and ethnic disparities in community living. So with this gap, our center conducts research and knowledge translation activities to identify the gaps and disparities within home and community-based services, or HCBS, for disabled people of color. HCBS are services and supports that enable people with disabilities of all ages to live independently and fully participate in their communities as they choose. Some examples of that, of those services are personal care, nursing level of care, behavioral supports, home modifications, respite, etc. The goals of our research center are to generate detailed new knowledge about participation disparities in community living, develop and identify effective systems change initiatives or promising practices that reduce community living participation disparities, and lastly, to serve as a national resource for community living and participation research that recognizes the unique challenges faced by disabled people of color and others from traditionally underserved communities. Just to give an example of some topics that we are researching, we are focused on identifying the long-term services and supports needs, utilization, and access for disabled people of color who need and desire HCBS. We're also collecting some qualitative data looking at the lived experiences of disabled people of color utilizing self-direction to support their lives. We're also identifying some peer support models in several case studies that are successfully aiding and assisting disabled people of color in accessing and utilizing HCBS. And lastly, we've partnered with Justice and Aging to develop policy recommendations and briefs on equity topics that are of priority to the disabled people of color in our community. In the space of this HCBS equity work, I'm really thrilled that Justice and Aging has developed a framework which is focused on HCBS equity that our center utilizes and guide our research and considerations as we do this work. I'm going to turn it over to Amber.
Thanks, Teresa. Hi, all. My name is Amber Christ. I use she, her pronouns, and we're definitely using the chairs today. We're doing real panel style, it feels like. I'm the Managing Director of Health Advocacy at Justice and Aging. I'm a white 43-year-old female. I have blondish hair. That's kind of wavy today, thanks to the DC humidity, but we're feeling a lot of air up here too, so it's a little chilly. Justice and Aging is a national organization. We focus on fighting senior poverty by securing economic security and affordable health care for low-income older adults. And we focus our work on marginalized older adults who've been excluded and denied from justice. So that's older adults of color, women, LGBTQ plus individuals, individuals with limited English proficiency, and immigrants. And as Teresa said, we are part of R5. We are doing policy analysis and development within the Community Living Equity Center. And we have developed an HCBS equity framework. Hold on, clicker. And I'll go through this in a little bit and describe what's up on the screen in just a second. But before I get into the HCBS equity framework, I kind of wanted to set a little bit of context to why we developed the framework. As Teresa noted, there's been just less attention to inequities in HCBS. But like in healthcare more broadly, the systemic drivers of inequities, racism, ableism, ageism, sexism, homophobia, and all intersecting are just as prevalent in HCBS. In fact, HCBS is more prone to inequities because the availability of HCBS is born out of discriminatory views of people with disabilities of all ages being less valuable to society, and then born out by segregating them and confining people with disabilities into congregate or institutional settings. And so those discriminatory views have been enshrined in federal Medicaid law, where it is required that states pay for and provide care in institutional settings like nursing facilities, but it's optional for states to provide home and community-based services. And a lot of work has gone into eliminating that institutional bias. But much work remains. It is deeply embedded, those discriminatory views, just like racism is deeply embedded, ableism is deeply embedded. And so there's a lot we need to do to intentionally unembed, to disrupt that status quo. And so that's how we came up with the HCBS equity framework. And just a caveat, the HCBS equity framework is not intended to be exhaustive or the end all be all. It's the start of a conversation, a tool, something that we can use to start to address the inequities in the HCBS system, to more intentionally evaluate the policies and program rules that guide HCBS programs. So I'm going to quickly, because we have very little time, walk through the 5 domains of the HCBS equity framework. So you can see the framework up here on the screen. It is demonstrated by a light orange arrow with the 5 domains across the arrow. So from HCBS program design all the way to the provision of HCBS. So we have program design, provider availability, awareness and application to HCBS programs, assessment and authorization of HCBS, and provision of HCBS. So if we talk about HCBS program design, so the very start of thinking about an HCBS program, first, are we engaging people with lived experience in the process of designing the HCBS program? What benefits are being offered by the HCBS program? Were those benefit design choices or benefit selection informed by people with lived experience, their families, caregivers? Where are HCBS located? Most HCBS programs are limited because they're provided through a Medicaid waiver, which means you can limit all kinds of things. So you can limit the people who are getting the services, you can limit where they're provided, and you can cap enrollment. And what we see is that inequities can arise on all of those decision points. So for example, where HCBS are located. There's a waiver program in Michigan, for example, that allocates slots to less populous, less diverse counties disproportionately in higher numbers than to more populous, more diverse counties. I'm sure that decision wasn't intentional to allocate slots that way, but no one was looking at it through an equity evaluation and that impact happening. So we should be looking at it, oh, how did we come up with that slot allocation decision? If we look at HCBS provider availability, which is that second domain, what does network adequacy look like? What are rate reimbursements for providers looking like? What kind of investments are we making in training and supports and services? All of those things are really necessary to think about what an equitable HCBS infrastructure would look like. But I just want to focus as an example on especially network adequacy and thinking about HCBS that are kind of site-based. Just like other like racial segregation in housing, we see racial segregation in the availability of HCBS site-based services. So assisted living, for example, we see assisted living more available in higher income and less diverse communities and neighborhoods than we see in less wealthy and more diverse neighborhoods. So we're seeing the same sort of racial segregation that is so prevalent in housing also playing out in the availability of HCBS. So that's provider availability. If we turn to awareness and application to HCBS programs, first of all, let me just say HCBS programs, it is a patchwork. It is so complex. And in a given state, you can have 5 to 6 HCBS programs, but you probably don't know you have 5 or 6 HCBS programs because they're called all kinds of things, My Choice and Senior Care Options. And like in California, the Money Follows the Person program is called California Community Transitions. All of these different programs are available in states, and there's actually no clear linkage that they're even Medicaid programs. So how do people even learn about these programs, right? Are the outreach materials in people's primary language? Are they in accessible format? Are they large print? What does the enrollment process look like? What kind of barriers are people facing? Do we have an enrollment process that's easy for people with cognitive impairments? All of these things are things we should be considering in awareness and application to HCBS programs. And then we've got assessment and authorization of HCBS. And we heard a lot about implicit bias this morning, and that is really prevalent in assessment and authorization services, both in the fact that individuals are making assessments and then authorizing, hours or what services folks are going to get. So people have their own personal biases, and we are all living, like all of us are living in a society in which all of these discriminatory messages and views are raining down on us all of the time. And so we're going to have these biases. How do we mitigate against them? Same with algorithms. Algorithms are made by people. How are we going to ensure and mitigate against all types of bias in our algorithms? So assessment and authorization of HCBS, and then finally provision of HCBS at the point of delivery of services. How are we ensuring that it's person-centered, that the services are being provided in a culturally competent way? We know, for example, LGBTQ plus individuals experience a ton of discrimination in the healthcare system. That is equally probably true in HCBS. Yet we don't have that kind of cultural competency training requirements in HCBS and for HCBS providers that we see often in the healthcare system. So how can we apply that here? Quality measures in the provision of services. CMS has released some quality measures, but obviously the states don't have to take them up yet. Although if you know what the access rule is, you should be commenting on it and agreeing that that CMS should adopt quality measures. But what do those quality measures look like? And if we're looking at them through an equity analysis, what does a truly quality measure that has an equity centered and looking at equity centered outcomes, what do those look like? So I'll just end with saying data. We heard this morning too. Data is absolutely essential across this entire framework. We have to have data to identify disparities, then to identify and then target strategies and come up with strategies to address those disparities, and then to evaluate whether those interventions and strategies are actually working as intended. So I will end there. I will say that our framework is available on Justice and Aging's website in our resource library, and I'm looking forward to the discussion.
Thank you. Should I just jump right in? Perfect. Hello, everyone. All right, my name's Andy Burstein. I am from Accessible Pharmacy Services. I'll spend a few minutes, I'll tell you a little bit about us. I'm really excited to be here. I want to just compliment you all, like you all do great work. Like everyone here does great work. Even the person here who does the least amount of work is awesome. Like literally, this whole event is unbelievable, and I'm excited for it to grow. And I'm really honored to be part of it. In the first, this is the first one, right? All right, cool. So that being said, I am a white male with a shaved head, a trimmed beard, and eyeglasses. I'm 54 years old. I live in tropical West Philadelphia, right on University of Pennsylvania's campus, for those of you who are familiar with Philadelphia. And I did my undergraduate studies here in DC at George Washington University. So it's really nice to be back here. That being said, what I'm going to share with you a little bit today is a case study. We happen to be the case study. Why are we the case study? And why is our story really important? And when we like talking about our story, but why is it an important story to tell? We are Accessible Pharmacy Services. We started as Accessible Pharmacy Services for the Blind. We are a home delivery pharmacy service and healthcare company specializing in patients who are blind, deafblind, and have low vision. We are the only provider of its kind in the world, and we are the largest blind-owned healthcare company in America. I started this company with my business partner, Dr. Alex Cohen. Alex is blind. Alex and I met, he's also my best friend. Alex and I met at Little League. Our kids used to play ball together. And many years back, I was running a healthcare marketing firm, and we were developing strategies for our clients around accessibility in general. Our clients were healthcare systems, the pharmaceutical industry, et cetera. And as we were developing this, I was like, I'm going to reach out to that blind guy from Little League, pick his brain. I want to go, what's his experience like in healthcare, right? So Alex, and I didn't know too much about Alex. Our kids are friendly. We live near each other. He's blind, and he's a really nice guy. So we met up for a cup of coffee, and I got to hear Alex's story. Alex was diagnosed with a degenerative retinal condition in his teens called retinitis pigmentosa. It's incurable. By the time Alex was 25, he was completely blind. Okay. He ultimately went back to school and earned a PhD. And he wrote his doctoral dissertation on the accessibility of the consumer experience for blind consumers in America at retail, online, and in healthcare, right? So I'm like, hang out with Alex. We'll talk about baseball. We'll talk about our kids. I'll learn a little bit from him. Little did I know, Alex is arguably the foremost expert in retail accessibility and healthcare accessibility in the world. And his academic studies are all about creating an inclusive healthcare experience. So obviously with Alex's knowledge, we started like building our business model, because we realized there's really nothing out there that exists, a healthcare company that was built from the ground up that focused on accessibility, that merged healthcare and accessibility, that empowered its patients to live independently, to manage medication, to manage diabetes with less stress, and to live a healthier life. And so we launched our company. So, thank you. I don't usually speak with PowerPoints because most of our audiences are blind, so I forgot that I had a PowerPoint here. All right, how do I do this? Thank you. All right, these are just some general statistics. I'll read them out loud, and I'll cut to the chase because I know we're tight on time. There are 282 million people worldwide who self-identify as having some type of issue with their vision. These numbers are increasing. For us, the way we experience it is through diabetes. 53% of our patients are diabetic, and diabetic retinopathy is a leading cause of blindness amongst our patients. Okay. So what kind of challenges? Let me pause for a second. I'm taking a step back. Our company is relatively new. We started in like 2019-ish. Fast forward to today, we now provide services in 29 states plus DC and Puerto Rico, and we're growing, and it's pretty cool. And our growth is really fueled by our patients. And I'll talk about that in a minute. But what kind of challenges does someone who's blind face when they're managing medication? So there's a few things I listed here. Identifying pills, reading a warning label and instructions, knowing a medication's expiration date, filling a syringe, pouring liquid medication. There are numerous challenges obviously related to monitoring glucose levels and managing diabetes, understanding drug interactions and side effects, understanding nutrition and medication interactions. See, I'm reading a monitor down here. If everyone is like, why is he like staring at the ground? There's a monitor down here. Okay. Safely administer medication to their children or to a parent or to a partner. Taking the correct medication, organizing medication, coordinating refills, coordinating prescription renewal, interacting with insurance companies. These are all challenges that are difficult. They're challenges. When you layer in the inability to see on top of that, they become very, very challenging and quite often dangerous. So I have this thing here, ask. Okay, I'll tell you how we build our business. This is the big secret. You don't have to write it down either. You can just listen. If you ask your patients how you can be more accessible, how you can be more supportive, what you're doing right or wrong, specifically in our situation with an underserved population, they talk our ears off in a very positive way. Our patients are driving the growth of our business because when we say to them, like, how are you managing your medication? Like, what's working for you? What's not working for you? What kind of solutions have you learned about in the marketplace? They tell us, and they've charted the growth of our business. And it's awesome. And it's something that we're actually, and I'll talk about this in a second. How am I with time? I'm good. Okay. I saw your wave. I was like, oh, shit. Okay. We're growing into other populations as well. And similarly, as we embark onto these other communities, we're asking them and they're telling us. And it's like I said, it's charting the growth of our business and it's providing solutions like in real time. So what are some of the things that we do? These are just, this is our case study. How do we help someone who is blind manage their medication? We have pre-sorted disposable pill organizers. Imagine someone who's older or takes a great deal of medication. There's 10 different pills and they're blind and they have to sort it and organize it in a pill organizer. We have compliance packaging that's pre-sorted. We have individual daily packets. We have standard and easy open bottles. We have single liquid doses of infant medication. So that parents who are blind, grandparents who are blind, babysitters or caregivers can safely administer medication to young children without the challenges of liquid pouring or administering. We have accessible labeling. We have traditional text labels in over 200 languages. We have grade 1 Braille and contracted Braille. We have extra large font labels with different color contrast backgrounds. We are able to print labels with fonts that are very favorable and easy to read for people with dyslexia. We have a collection of audio labels that read medication information out loud. We have our own technology that we've developed with Apple and the Helen Keller National Center for people who are deafblind. But there's a company out there called Script Talk and Vision America who are like pioneers in this space. And they created talking medication labels years back. We use QR codes. We're actually part of a pilot program now with OpenAI and Be My Eyes to test artificial intelligence for label reading and medication identification, which is like, it's awesome. It's like science fiction. Then there's also support. What's the easiest way for our patient? We try to remove barriers to access. So our telephone is the easiest way to communicate with our patients. We use Be My Eyes. So for those of you who aren't familiar with Be My Eyes, it's almost like a one-way FaceTime that connects blind users and sighted either volunteers or professionals. There are currently 500,000 blind users in America that use it and 5 million volunteers. We use Zoom pretty routinely, specifically for education. We find it to be one of the more accessible telecommunication platforms. We use video relay services, VRS. For those who aren't familiar, it's essentially on-demand sign language interpreters. It's a federally funded program. So for someone who is deaf, if they qualify, they can contact an operator. Like if I were deaf, I would contact an operator. I would say, I wouldn't call the audience here. That operator would call you and say, hey, everyone, I have Andy on the phone. He's deaf. I'm going to translate for you. And it's awesome. It helps us have a much more seamless conversation with an individual who is deaf. Obviously, we communicate via text and email as well. The big growth of our company is because of our universal design. Because of what we do, other populations have gravitated towards us. And while our core competency and our initial focus was really on individuals with issues with their vision, we now have an exploding collection of exploding my slide. We have a growing collection of patients in the deaf community, in the paralysis community. We're actually developing with Temple University's Disability Studies program, medication packaging for individuals in the paralysis community, the neurodiverse community, seniors, refugees and asylum seekers. The refugees and asylum seekers are pretty interesting. It started in the fall. Because of our talking medication labels, we had there's a county in Pennsylvania, their Department of Health called us. And they said, we have a bunch of Afghani refugees under our care. They don't speak a word of English, and about half of them are illiterate. We heard about your talking medication labels. Can they speak medication information in Pashto and Dari? We were like, huh, kind of interesting. So we now provide services to refugees and asylum seekers in over 200 different languages through a multitude of packaging and labeling, education and communication. We have a lot to learn there. It's a very intense undertaking, but it's very rewarding and very awesome. We're in the process right now. We're involved with 3 different studies. One is with the Pennsylvania Department of Aging. We have a cohort of 200 patients. Follow this. They're over the age of 65. They fall below a certain income level. They are insulin dependent diabetic, and they've had an impact on their vision, ranging from low vision or deteriorating vision to complete blindness. And our interventions are designed to figure out, the things that we do, can they get them to be healthier? That's a quick summary. We're in the process of initiating a study with Ukrainian refugees and medication management. And we're about to embark on a study this winter with the United States military, focusing on military veterans who have either lost their eyesight due to combat or situations in the military, or just naturally over time, or because of some other circumstance. Once again, everyone, when you go back to your office, if you want to figure out, hey, how can we be more accessible? It's really easy. Ask your patients, ask your colleagues, ask the caregivers who you work with, ask the healthcare providers who you interact with. If you ask them sincerely, they'll tell you. It's pretty cool. Thank you again, everyone. My name is Andy Burstein. Check out our website. It's accessiblepharmacy.com. And the punchline to that is it's a screen reader friendly and large font website. And what do I mean by that? For those of you who don't know, someone who's blind, the way they use the internet is they use technology called screen readers. And it essentially reads websites out loud to them. It also benefits individuals with cognitive disabilities, individuals who don't speak the language. But it's very important you check, because not all websites are compatible with screen readers. So talk to your IT department, talk to your patients, caregivers, et cetera, et cetera, et cetera. Thank you again, everyone. I'm excited to hear everyone else too. That's it.
Thank you. Good afternoon, everyone. My name is Erica Reaves. I identify as a Black woman, as a health equity accomplice, and a public health practitioner. And I have the pleasure of co-presenting with my colleague, Madeleine Shea, who will introduce herself in a moment, but really to highlight the work being done in Georgia by our clients, Georgians for a Healthy Future. So just to frame the issues and the opportunities before we get into the data, and on the first point, I think I could talk for an hour, but I will limit my comments, but really to highlight the Olmstead decision, the landmark Supreme Court decision in 1999, which really set the basis for a paradigm shift in terms of institutionalization for people with disabilities and older adults, and expanding access to home and community-based services to advance the notion of aging in place with independence and with dignity for all. And so Olmstead versus Lois Curtis really upheld the integration mandate within the American with Disabilities Act. And I'll pause for a moment here to encourage you, as you have time and interest, to look into Lois Curtis, who unfortunately passed away last year at the age of 55 due to pancreatic cancer. But as one of the co-plaintiffs in this case, hearing her story, reading her story as a self-advocate, as a community advocate, and as an artist is truly inspiring. So again, I encourage you to read about Ms. Curtis if you have not yet familiarized yourself with her life and her work. On the second point, in terms of access to affordable and accessible and sustainable and safe housing for persons with intellectual and developmental disabilities, older adults, physical disabilities, when there's not access to that type of housing, there's an increased risk for institutionalization, homelessness, and poor health and poor social outcomes among individuals with disabilities. And here, for the purpose of this work, we focused on those with intellectual and developmental disabilities residing in Georgia. We also heard through our research and from our client that members, family members, advocates, and providers, as well as people with intellectual and developmental disabilities, are reporting barriers, structural barriers, institutional barriers, and interpersonal barriers as they seek community integrated housing and other supportive services. And really what this work was a novel opportunity to hear from those individuals themselves about their lived experiences in seeking housing in the community. And also, and really driving this work, was the fact that state-specific data is truly uncommon and rarely examines housing needs and challenges among those individuals with disabilities from their perspective and across personal identities such as race, ethnicity, age, and gender, and at the intersection of those identities. And so again, this opportunity to conduct this survey in partnership with our client was again to gain those lived experiences from the perspective of those people with intellectual and developmental disabilities. So this is a project description, and you should follow the 6 boxes, text boxes in clockwise order. But first, to highlight the project goals, they were twofold. First was to increase understanding of housing challenges experienced by a person with intellectual and developmental disabilities and their family members. And again, this was restricted to individuals residing in the state of Georgia. And to also identify policies to address those barriers to independent living and community integration for this population. So in November of 2021, Georgians for a Healthy Future, who is our client in this work, submitted a grant application to the Georgia Council for Developmental Disabilities. And in March of last year, contracted with Health Management Associates. I forgot to mention, I'm a senior consultant with Health Management Associates, to support a leadership group which comprise individuals with developmental disabilities, their family members, friends, and other community leaders, to support a survey design and then implementation of that survey and then analysis of the survey, as well as some focus groups. And so in June of last year, Georgians for a Healthy Future convened their leadership group. And again, this was a group consisting of residents with IDD, as well as their family members, to really lead and advise the project. And that's where we had the majority of our interaction was in developing the survey. Fall of last year, we launched a web-based survey and then also facilitated focus groups. And I want to shout out my colleague, Akiva, who's in the audience, who was one of the facilitators for the focus groups. Thank you. And also later then, we analyzed the survey data and the focus group data. And just on May 25th of this year, the Georgians for a Healthy Future, as well as the Georgia Council on Developmental Disabilities, co-hosted a virtual event to discuss affordable, accessible housing options in Georgia. And so with that, I will pass the mic down to my colleague.
Thank you, Erica. So my name is Madeleine Shea. I'm a principal at Health Management Associates out of the Baltimore office. My pronouns are she, her, hers. I am short-statured, but it doesn't matter. We're all sittings. Great equalizer. And I am wearing mostly black, but I have like a floral with green jacket on. And my eyes are expressing gratitude to those in the audience who decided they wouldn't even worry about the traffic when they leave today. This was some of the most exciting work I have done at Health Management Associates, because honestly, I don't think we've ever asked people, at least nothing that's published, people with intellectual and developmental disabilities, what was important to them in terms of their housing. And you can see from these results, we got over 1,217 respondents respondents who had intellectual and developmental disabilities themselves out of the 1,684 respondents, representing 74% of Georgia's counties. So I just consider that such a tremendous result. So in terms of gender identity, 52% were men, 40% were women, including transgender women, 6% were genderqueer, 1% non-binary, and 1% other. So we had really, people really were identifying their gender. For race ethnicity, 54% were white, followed by Black, African American, where 20% identified as that, American Indian or Alaska Native, 14%, Hispanic Latino, 10%, Native Hawaiian or Pacific Islander, 7%, and Asian, 4%. In terms of age, 63% were of the persons with intellectual and developmental disabilities were under the age of 35. 96% reported receiving a government benefit, and that was predominantly Medicaid coverage or SSDI. Okay. So these results on this slide are for the respondents who had intellectual and developmental disabilities as opposed to their caregivers. 70% lived in community settings, apartment condos, 28%, single family townhouses, 24%, multifamily home duplexes, 18%, 55% lived with family members, 19% lived alone, and 24% with non-related roommates. 4% were currently homeless. 66% reported sufficient income to meet their housing-related expenses. And 27%, so more than a quarter, really didn't have enough money to meet their expenses. 88% had moved less than 3 times in the past 5 years. But reasons for moving did include lack of physical accessibility of homes, the cost of rent, and lack of reliable and accessible transportation. You can see that, almost half reported that it was challenging to find a home in the community that fit their needs. Talk about visually impaired here. I am using my much bigger print. So also 49% required less than 3 hours of support a day on an on-call basis, but 8% needed 24/7 supports at home. So supports 7 days a week, 24 hours a day. Half made decisions with support from people they trust, typically parents, 34% of that, and 15% made their decisions independently. Most important aspects of the living situation and their community was safety, proximity to family, and affordability. And again, I just want to point out, I don't know of any research like this where we've really asked people what matters to them, asking, why, how. So, so the themes from the caregiver focus groups, and again, thank you, Akiba, for the facilitating fabulous focus groups, was limited housing supply. There's really limited options for community-based housing for persons with intellectual and developmental disabilities who want to live independently. There's limited housing resources, like how to find housing, limited services and supports. So these would be, riffing off what you've been talking about with HCBS, there aren't enough person-centered services and supports to help people to live independently in their own homes. And we know that there really is an injustice in the way our resources are distributed in that regard. Direct service workforce shortages, we all know that is just a huge issue all over the place, but finding direct service workers who, for people with intellectual and developmental disabilities is really tough. And then you have the issue of parents who are aging. So care planning for aging parents and guardians who want to really make sure that they're doing right by their children is really hard and unsustainable. I'm going to hand it back to Erica.
Thank you. Team effort. Thank you. So in closing, just to highlight some opportunities for policy intervention, and this is really picking up on the continued work from Georgians for a Healthy Future. And I mentioned they had a virtual event at the end of May titled Realizing the Promise of Olmsted. So the 7 opportunities listed here, the first being a standing work group to convene state agencies, residents with intellectual and developmental disabilities, as well as caregivers to address housing needs, again, focused on the specific population, an effort to continue to hear about their needs, their wants from their perspective based on their lived experiences. Number 2, picking up on a theme from the caregiver focus groups around direct care worker shortages, also this idea of wage increases to really support direct service professionals or support professionals with a living wage. The third is around transition supports. So expanding access to services and supports for caregivers who want to transition family members safely, sustainably into a new living situation. Again, picking up on Maddie's point about those who are aging into older adulthood and who are worried about their children or those they provide care for and what will be their living situation in the years to come. As a fourth opportunity is state appropriation for housing, so requiring the Georgia Department of Community Affairs to set aside 10% of the low-income housing tax credit to fund affordable housing for people with disabilities. The fifth being developing a Section 1115 Medicaid demonstration waiver to address housing needs among enrollees living with a disability. I know there have been many sessions at the conference that have touched on what states are doing, what states are proposing to do in terms of building in housing supports for several populations. The sixth being technical assistance for housing stakeholders. So working with developers, community partners to meet housing needs that are identified and prioritized by individuals with developmental disabilities. And the last being a universal design standard compliance. So requiring housers who are state funded to comply with those design standards to ensure accessibility, because our survey results showed that accessibility was a challenge or a barrier to remaining in the community and aging in place for individuals with intellectual and developmental disabilities, as well as a concern for family caregivers. So this is our contact information, as well as that of Laura Colbert with Georgians for a Healthy Future, who's their executive director. So please feel free to reach out if you have questions or comments. Thank you.
Well, a huge thanks to our panelists for offering your perspectives and insights. We have, I think, about 15 minutes for any question and answers that you all may have. So let me check. Are there any on the web platform? Okay. I may take facilitator's prerogative and ask one of my own. You know, all of you covered on such a diverse set of topics and a diverse set of people in talking about the challenges facing individuals with disabilities. One of the themes that I think kind of cut across your presentations was the need for supportive workforce to meet the needs of those communities. I wonder if you could talk a little bit about what the workforce challenges in your respective spaces look like and any ideas about potential solutions.
We employ people from the population we serve. 25% of our employees are blind. And similarly, like, you know, does that address your question? That point of like, okay,
Yeah.
You know, there are challenges related to employment amongst individuals with disabilities, and there are a whole host of issues related to it. And so there's a great deal of mutual benefit by employing individuals who are blind. One, We get to learn from our employees. 2, we're able to, for lack of a better term, like give back to the community. And 3, there's obviously a marketing benefit to it, to the population we serve, to know that we employ people. 72% of blind adults are unemployed. And the other 38%, 38, a significant chunk of them are underemployed. And so similarly, like, to actually the populations we serve, like quite often they're looking for employment. And so to pull them in there, because there are mutual benefits, multiple benefits for creating that employment.
And we're currently working with one state and developing their direct service workforce plan. So just to highlight some of those issues. So from an equity perspective, looking at the direct care worker population, the majority are women, the majority are women of color. So when we talk about wage increases, we're talking about sustainability, household, and the like. So I think trying to move towards a livable wage will have implications for those individuals and families. We have also been supporting this particular state in trying to get a handle on training. So there are, basic core competencies, but then by population, additional training requirements. And then there's the training that happens in the individual's home, how they want their meal prepared, how they want you to support them in changing dressing or, and having an outing where they want to go. So there's that additional training that happens. I would say some other issues are, picking up on our work, hearing from the lived perspective of direct service workers, they have a direct service workforce advisory board. So any decision that the state makes has first been run by this board, very robust discussion where they're trying to gauge, again, lived experiences. How would this work for you on the ground before the state moves forward? I would also say, and I'm smiling because it's an ongoing issue, and I imagine it's the same in other states. They are direct care workers, direct service professionals, direct support professionals. So all of these naming conventions and trying to get a handle on the nomenclature and really standardize those terms in their state statute and code so that we can get on the same page about who we're talking about. And again, that goes into training, wage increases and the like. So no shortage of issues in addressing the shortages, but I think the approach has been to continue to engage what we're calling direct service workers themselves. And again, to double check our understanding of what's happening in the field.
Yeah, and I can kind of close us out, but I think in terms of research, policymaking, data collection, I think we need more people with lived experience in these spaces to lead the processes, the policymaking decisions, and the implementation on the ground. And so I think, a lot more capacity building in academia for the research in these topics, and a lot more leadership positions and encouragement for people with lived experience to take part in the federal and the local systems.
Any last questions? Yes, ma'am.
Hi, Natalie Akin, also with Justice and Aging, colleague of Amber. My question's for Madeleine and Erica about the data. Well, 2 questions. One, how did you decide on the age 35 division to look at your data, and were there any older adults that participated? And then did you do any intersectional analysis of, some of the responses of what people need or, issues they're facing
Thank you for the question. So I'm trying to think of back to the age categories. So that would have been a decision by this leadership group. And I can't recall the exact discussion about how the breakdowns happen, but we certainly did have an age category for 65 plus. And I'm happy to follow up with you about the outcome of that question. And as far as looking at the intersections, so our preliminary analysis did not look at intersections, and I'd have to follow up with Georgians for a Healthy Future to see if they did those breakdowns. It was a somewhat limited engagement building up to this opportunity in May for Georgians for a Healthy Future to convene with these other housing groups, but happy to follow up with you with more information.
In the back, yes, ma'am.
Oh, absolutely. Well, we're a closed door pharmacy, so no one actually comes to visit us. Everything is delivered. So we rarely, if ever, have a one-on-one in-person conversation. Once again, it's on demand of the patient. It's personalized medication. The first is we're agnostic towards solutions. We start that conversation breaking down the patient, asking them the questions, what their challenges are, what works for them, what kind of solutions have they experienced. And then we almost have like a menu. There's a combination of a few things. We're like, okay, so you're still able to see and you have low vision. Well, here are a few solutions we have for someone like that. So that's one thing. The second thing is we create patient profiles that become best practices. So the first time we deal with a patient who is, completely blind and losing their hearing, and they have some dexterity issues, and they live by themselves, but their nephew stops by once a week to check on them, and the post office always hides packages behind the bush so that they can't find them because they're blind. So we break down the patient and we identify that patient and we come up with a solution for that individual. Okay, so now the next time another patient calls us and says, here are my issues. I'm blind, I'm losing my hearing, my nephew comes in, I have a problem with the post office. We're like, okay, we have another patient who's had a similar experience as yours. That doesn't mean that those solutions are going to be exactly beneficial to you, but why don't we try that out for a month and let's see if that works. And when you get the medication, why don't you call us and we'll explain to you what's in the packaging. It requires many more touch points, virtual touch points, this is. If they can't see and they're still struggling around it, we engage them through Be My Eyes or another platform where we can see what's in front of them. And we'll help them. I'll give you an example. We did thousands of home COVID tests with blind Americans where they would have a test, they would contact us through Be My Eyes or another platform. We would see what's in front of them. We would help them navigate, understand all the components, navigate the test, and then understand the results. And so that's an example of an intervention. So I hope that answered your question or got close to answering your question.
So there's this discussion around how pharmacy can be a way to promote accessibility in communities because it's an easier touch point. There's trust there, things like that. And so thinking about how even in these virtual relationships, you're still able to leverage that.
Oh, sure.
And build it as.
You know something really cool we do? We have a summer internship program. This will be our third summer. We employ blind college students who want to pursue careers in healthcare. And we give them a bunch of tasks. One of their tasks is actually mystery shopping. What do I mean by that? They are responsible for calling pharmacies, local pharmacies, national pharmacies, emailing pharmacies, walking into pharmacies and asking them presenting themselves obviously as a blind individual saying how can you help me? The good and the bad of that, the good from a business perspective, no one else has an answer for them. But we're starting to learn over time because every once in a while you bump into a situation with a pharmacy who does have a really unique approach to that. And so we're able to learn from that. And then ultimately we disclose to them what we're, it's not top secret, this is what we do. We actually share the knowledge back to them. And some of them actually embrace it and, do things at the local level with their pharmacy.
Got it. Thank you. And also just thanks to the panel. My biggest takeaway is ask. And you obviously will hear so much really valuable information. So thank you.
Well, I think we are just about at time. How about one more round of applause for our wonderful panel? So I think your agendas say that we're